in COVID-19 panel with Dr. Keila Lopez. A quick introduction for Dr. Keila Lopez. She's an assistant professor at the Baylor College of Medicine and is a pediatric cardiologist. She completed her master's in public health at the Harvard School of Public Health with an emphasis on healthcare management and minority health policy. Dr. Lopez's research interests focus on identifying healthcare disparities among minority and underserved children, particularly as they pertain to the field of pediatric cardiology. She is also working on developing educational programs for low literacy and low English proficiency parents of children with complex congenital heart disease, as well as educational programs for pediatricians and pediatric cardiologists to improve oral health screening and access to care. Thank you, Dr. Lopez.
Hey, everybody, can you hear me?
Yeah.
All right, so I'm gonna go ahead and start sharing my screen here. Hold on.
Oh, yeah, just a quick message for anyone that just joined in. If you could please turn on your camera, that would be greatly appreciated. All right.
All right, you guys. So I'm a pediatric cardiologist, like you said, at Texas Children's Hospital. And so in medicine, we need to be able to see people to make things work. Okay. So that means I need to be able to see you to make this work. So I'm going to ask you guys to all turn on your cameras, everybody. I know we are super pumped to be here on a Saturday morning. Actually, it's almost Saturday afternoon at this point. So everybody turn on your cameras if you can, or try really hard because I like to call on people, and I tend to call on people whose cameras are not on, for what it's worth. And so I like to ask for participation that way, because that way I know that you're listening. So that's really, really helpful. Okay. So I'm here to talk to you guys about community health and social determinants of health. These are lots of terms that you'll hear when we talk about COVID-19. So this lecture requires participation. And I don't mean participation in a chat somewhere that I can't see because I have like these slides up. I'm talking about verbal participation. Okay, I need to hear you, and I want to hear what you have to say. I want to hear your voices because your voices matter. All right. So I'll ask a few questions, and if I don't hear anything, I'll just start calling on names for you guys to participate because I know everyone at least has a mic. All right. So can anyone out there tell me what is population health? Start with a general one. What is population health? What does that mean? Not a trick question.
It's like the health through a group of like individuals or a group of people.
Yeah, it's the health of a population, a group of people. Perfect. And so it is just that. So it can mean a big group of people like Houston. It can mean a specific group of people like Latinos in Houston. It can be any particular population that you choose. All right. What about public health? What's public health? What's like, because there's two differences, two different panels there. What is public health? All right, can I get Gardelia Roman? What is public health? Any thoughts?
Is it like health for like an individual person?
So public health, so you're thinking it can be for an individual person because everyone participates in public health. Yeah. But more specifically, these are things that we use to improve the health of a population. So these are the tools that we use to help to make a healthy population. And so when we're talking about disease prevention and health promotion, these are the things that we use to make individuals, as Gardelia stated, healthy. And so this can be at any level. This can be from the environment to medical care to behaviors to lifestyle. It's a spectrum of different things. And so depending on what we're looking for, public health takes lots of different forms. So, for example, looking at lead in water, that's public health. Looking at people who have access to healthy foods, that's public health. Looking at how safe a neighborhood is, that's public health. All right, so what is the difference between all of those things and community health? Can anyone tell me what's the story with community health versus population health versus public health?
Miss Dr. Keila Lopez, or I know you can't see the chat, so just wanted to let you know Orlando Gomez said healthcare for the community.
Oh, here, let me see if I can pull this up here. Healthcare for the community, so for a specific community. All right, and so it focuses on the physical and mental well-being of people in a specific community. That's right. So it's the health, not just the health care, but just the health. So it's the important section of public health. So having initiatives to help community members and maintain and improve their health and prevent the spread of infectious diseases and prepare for natural disasters. And then looking at strong community health requires residents to look beyond themselves. So this requires you to think about other people in your community, because if you're just thinking about yourself and you're not thinking about everyone else, that doesn't really help the health of the community. So when you're thinking about things like COVID-19, the health of the community really involves having you think about everyone else around you, which is why things like masks and social distancing are important for a community. Okay. All right. So other things about community health, it is tied to your individual wellness. It impacts all of the things. So the health of your community impacts everything. It impacts your educational achievement. It impacts safety. It impacts your ability to go to work, transportation, how long you live, how happy you are. And it also impacts how much money you can make, how you interact with the healthcare system. Like, do you get to go to a good hospital versus a bad hospital? And then health equity and social economic disparities, if that's a term that you guys have heard. These are concerns that community health organizers have when they're looking beyond the clinical sphere. So this is kind of beyond the doctor's office, right? When we're looking at what makes people healthy, we look at some of these factors in community health to help us make communities healthier. So chronic diseases such as diabetes and heart disease can increase if a community is overall less healthy. So if you look at different communities, depending on the health of that community, they can have more or less of these chronic diseases. So not only does it reduce how long people live, but it can also impact what the economy is, like how much money that community can make, which of course impacts how good the schools are. It impacts how many grocery stores you have, etc. And so what's amazing is that the CDC, the Centers for Disease Control, report that 90% of the nation's healthcare expenses are for people with chronic conditions. So we are really active at kind of addressing a lot of things that a lot of diseases that people have. And that's okay, but it would be much, much better if we were able to intervene before someone had a chronic disease, for example, or stop it before it happens. Because once you have a chronic disease, it's a little more challenging to kind of go backwards. Okay. So let's talk about COVID-19 and chronic disease. So can anyone tell me what are some of the underlying medical conditions related to hospitalizations with COVID-19? What are some of the things that you guys have heard? Like, if you have this disease, this underlying disease, your outcomes are going to be worse if you have COVID-19. Can anyone give me examples?
Asthma.
Say it again.
Diabetes.
Excellent. Diabetes is one of them. Someone wrote asthma. Excellent.
Pneumonia.
So if you, usually COVID-19 can lead to pneumonia. So it's definitely associated. I don't know if it's the underlying medical condition that you have before COVID-19, but it is associated with COVID-19. How about diseases that you can have that make you at a higher risk for getting COVID-19 or for having a worse outcome with COVID-19?
Cancer.
That's what. Okay, so if you're immunosuppressed and you have cancer, that's a good one. Asthma, cancer. If you're a smoker, sure. If someone wrote vomiting and coughing, so if you cough a lot, chances are you might have some underlying lung disease. So underlying lung diseases also. There's two other major ones that now again, these are not things that COVID-19 causes. These are diseases that you have before you got COVID-19 that make your COVID-19 worse. Two other big ones.
Diabetes.
So someone else said diabetes, and that's exactly right. Age is
Hypertension?
definitely a factor. Someone said age. Oh, someone just said it. Say it again. What did you say?
Hypertension?
Hypertension. So high blood pressure is a big one. And there's one more big one.
Cardiac illnesses?
So if you have a heart problem, certainly you're going to be worse off because your heart's going to have a harder time fighting. So for sure, although less people tend to have that problem, this one problem that I'm thinking about is very common in the United States. Very common. It's very common in the South of America.
Obesity?
Obesity. Perfect. So obesity is definitely on this list. So let's talk about it. Let's talk about your risks if you have any of these underlying conditions and what the likelihood is of you getting hospitalized because you have one of these conditions. So can anyone tell me how much more likely you are to get hospitalized if you have asthma? You can say 3 times more likely, 2 times more likely, 1.5 times more likely. How much more likely are you to get hospitalized if you have asthma?
3 times.
So that's a 3 times guess. Anyone else? I have here 3 to 4, 3 times. Okay. How about if you have obesity?
6?
6 times, 5 times. I'm hearing, 8 times. Wow, someone took it to the next level. Okay. And then how about if you have diabetes?
Probably 8 times or 5 times.
Yeah, so probably a lot higher. How about if you have, sometimes if you have obesity, you also then have hypertension and also have diabetes, right? So these things kind of work together, they come together. How about if you have more than one? Do you think your risk is higher or lower?
Much, much higher.
Yeah, much, much higher. So let's take a look. All right. So here's what we have. If you have asthma, your likelihood of getting hospitalized is 1.5 times greater. If you have hypertension, 3 times greater. Obesity, 3 times greater. Diabetes, 3 times greater. One that we didn't talk about, having a kidney problem, 4 times greater. If you have 2 or more of these conditions, your likelihood of getting hospitalized with COVID-19 is 4.5 times higher. If you have 3 or more of these conditions, your likelihood of getting hospitalized is 5 times higher. So you can see that these things kind of all go together. So when people talk about why is it that certain communities are doing worse with COVID-19, this goes back to our whole concept of community health and what is the health in that community. And it goes back to the concept of public health. What tools are we using in that community to try to reduce the spread of a disease or try to make people's general outcomes better? So why is it that certain individuals have worse underlying medical conditions? Why is it that certain communities have these problems and other ones don't? Like, for example, why does the 3rd ward have such a higher rate of diabetes and obesity and hypertension and Westview doesn't? Why is that?
Inadequate access to healthcare?
Inadequate access to healthcare is a good one. So maybe having less insurance or something. But why did that happen in the first place? Why is there inadequate access to care? Why?
They can't afford it as much.
They can't afford it. So there's an economic problem, right? So they're more poor. Why is that? Why are they more poor? So let's dig deeper.
They don't have the jobs to provide the money for them.
So they don't have the jobs, thus they're poorer. But why don't they have the jobs? Dig deeper.
Education.
They don't have the right education or they don't have good education. Why is that? You guys are coming up with great ideas, but why?
They weren't raised in like a higher class like place where they had access to good education.
So why do some communities have access to less good education? Why is that? Why are some communities good education, some communities less good educations? How did that happen?
I think it was called the cycle of poverty, in which
Go ahead.
in which if you are born into poverty, you're more likely to stay into it, and it's hard to escape.
So that's right. So it is a cycle, right? So if you're born into it, it is harder to escape from it because your access to certain things that give other people the edge, you have less access to things like, for example, SAT prep or higher school scores, things like this. So you're right. Or even knowing how to apply to college, having good guidance counselors, right? So the underlying reason to all of this, the whole big reason why all of this is happening, why do certain communities are less well off? Why are they more poor? Why do they have worse health outcomes? Why do they have more underlying disease? The whole reason for all of this is racism. Okay. So systemic inequities, having communities that are more poor, having communities that have less good education, having communities that have more obesity and hypertension, having communities that don't have good education, all of that stems from racism in America. Okay. And so there's different kinds of racism. There's different levels of racism. So systemic racism, institutional racism, interpersonal racism, and internalized racism. These are all different kinds of racism. And for the purposes of this talk, I'm going to focus mostly on systemic and institutional. But I will say this, that people, that interpersonal racism is the racism that one person has towards another. And internalized racism is that you've heard something so often about people that look like you that you begin to believe it yourself. So for example, you've heard that in my example, that Latinos are less smart because they go to school less. And so I begin to believe that lie, and I'm internalizing the racism that others are putting on me. Okay, so we're not going to spend much time talking about those. But as far as the rest of these systemic racism, this is one of the main reasons that we're talking about here. So in a lot of ways, systemic racism is the silent opportunity killer. Okay, it is the interaction between how institutions and policies and practices continue to perpetuate these barriers to opportunities and perpetuate racial disparities. And so institutional racism is when you have systems of power, hospitals, schools, police units, etc., that routinely produce racially inequitable outcomes for people of color and advantages for white people. So I'm going to give you guys an example of how this happened, okay? So this here is a map of Philadelphia. And this map of Philadelphia shows a variety of different colors. So the Great Depression happened in the early 30s in the United States. That's when the market crashed. People lost a ton of money. And so no one had the money to buy a house. And so Congress made this thing called the Homeowners Loan Corporation. They said, okay, we're going to give a lot of people help to buy a house. And between 1933 and 1936, they helped about 1 million households. And what they ended up doing was they ended up making these maps that you can see there that were colored according to how they labeled the different grades of a neighborhood. So grade A neighborhoods were the ones here that are in green. And these are the best neighborhoods. They were the ones that were the most ethnically homogenous, so people looked the same, and they had a lot of room to be developed. Grade D, or the worst neighborhoods, were the ones that were hazardous. These are the ones colored in red. And these are the ones that had low home ownership rates, older houses, and what people called at that time undesirable populations, which meant populations at that time, which people referred to as Jewish populations and African Americans. That's how people had termed it back then. And so if you lived in one of those neighborhoods, these maps ended up in a system that was called redlining. And redlining is the practice of saying, if you live in a red neighborhood, we're not going to give you any high quality schools. We're not going to give you any high quality grocery stores. You're not going to get more money for housing. You're going to try to get a lending for a business. We're not going to give it to you because you live in this red line neighborhood. And so people that lived in these neighborhoods had less wealth and income because they couldn't get to good schools, because they couldn't live in good areas, because they couldn't get good jobs, et cetera, et cetera. And that meant that those neighborhoods got worse and worse and worse over time, which meant that less people were going to school, less people were employed, less people had access to healthcare insurance and quality healthcare, and people's health deteriorated in these areas. And so it turns out that where you live is actually linked to how long you live. And that is actually true in Houston. So let's look at this map for a second here. So this is where I'm from. I'm from Chicago, all right? I'm from the north side of Chicago. And the north side of Chicago, can you guys see this arrow over here? Yeah, okay. So the north side of Chicago is up here. And you can see that the life expectancy up here in Chicago on the north side is 81 years. I worked, when I was training to be a pediatrician, I worked on the south side of Chicago, where the life expectancy is 69 years. And then I went to medical school on the west side of Chicago, where the life expectancy is 72 years. And so basically, just because I'm from and lived on the north side of Chicago, my life expectancy was 11 years higher than anyone who lived in the south side of Chicago for the reasons that we just discussed. Okay. And so this is this is true not only for Philadelphia, but this happened all over America, these red line districts. And it ended up resulting in good neighborhoods, bad neighborhoods, different levels of taxes, different degrees of schools, education, healthcare, etc. So can anyone tell me, what do we think about the life expectancy in Harris County? What is the difference between the best life expectancy in Harris County and the worst? Thoughts? Yell it out.
It's probably relatively higher than Houston itself, like downtown area and stuff like that.
So downtown having a higher life expectancy?
Oh, no. Like areas like the suburbs of Houston probably have higher expectancy, higher.
Okay. So the suburbs, what is the actual, so someone wrote there 10 years. What is the actual life expectancy? Do you guys think that is the difference between the highest and the lowest? How many years difference between the neighborhoods that live the longest and the neighborhoods that live the least long? Someone wrote 5 years, 20 years,
12 years.
12 years, 15 years. So we're kind of running the
Yeah,
gamut here.
15 years.
Okay. And let me ask you one more question. Where do you think in Houston that the worst life expectancy is?
Probably downtown, south side.
So someone's
The
writing
south-
south side. Someone said
southeast.
southeast. Okay. Someone's writing Greens Point, Sunnyside. All right. So let's take a look at the map. Third Ward. Excellent answer. Third Ward, Fifth Ward. So Third Ward, Fifth Ward, Baytown, Pasadena are the winners of the least life expectancy in Harris County. Okay. And here's the map. So you can see here that this here represents Third Ward and near the Fifth Ward. And you can see that these people, their life expectancy is less than 70 years of age. Whereas if you go to places like West U and River Oaks down here, you can see that the life expectancy is 86.5. So the life expectancy difference in Houston is at least 16 years, solely based on where you live. So that's astounding. That's a huge number. So let's take a look at that. And so if we're thinking about, and we've talked about community health and about how different communities have different health based on where you, in part based on where you live. Do you guys think that COVID-19 disproportionately affects different communities based on where you live?
Definitely.
Yeah, right. Because we talked about underlying disorders that disproportionately affect different communities, right? So let's take a look at an example over here. Let's take a look here at Bel Air / River Oaks / Westview. That's the area that's circled over there. Okay. So looking at that area, tell me, who do you think lives in that area? Do you think it is mostly Caucasians, Latinos, African Americans, Asians? Who do we think lives there primarily?
Caucasian or Caucasians.
Caucasians, right? So someone wrote white people here. Yes, Caucasians. Okay, so let's take a look. So here's the same map, and you can see this is the population density of Caucasians. Okay, and the darker it is, the more Caucasians there are. So putting the circle over there, the vast majority of this area is indeed Caucasians. Okay, so now we're going to look at a map of COVID-19 real quick. And you can see here that this is the number of cases by zip code here. And you can see that the lesser number of cases are where there is lighter colors over here, right? So let's take a look and circle it again. And you can see there that most of those areas are more lightly colored, right? And if we're looking at areas that are closer to Third Ward, areas that are closer to Pasadena, Baytown, the colors tend to be somewhat darker. And so you can see that a lot of the things that we see with systemic inequities and systemic racism have to do with what we talked about in terms of this redlining district, but it also created systems of disproportionate communities in terms of having diversity within those communities. And so that is part of the reason why when people say, why is it that all these Latinos and Black people are getting disproportionately affected by COVID? This is part of the reason why, because of long-standing historical systemic inequities. So let's talk about that term for a second. All right, so health equality versus health equity. So these are different terms that we use in public health all the time. And these are the ones that I think help people understand a lot about the differences between equity, equality, and what we call justice. So you can see there that there's a soccer game that's going on. And on the left-hand panel there's a bunch of people trying to watch a soccer game. And so equality, when people talk about equality, people assume that everyone will benefit from the same support. And that is because they're being treated equally, and everyone should be just fine with being treated equally because they need this, they're getting the same support. And what's wrong with that? Well, you can see in that game there that the guy on the left-hand side has access to the game, right? The guy in the middle has access to the game, but the poor person on the right who was given the same benefit, the same support, has zero access to the game, can't see at all. So while they're getting the same support, they're getting equal support, their access is different. If you're looking at the middle panel, which is the one that is looking at equitable treatment, people get the support that they need based on where they started. So you can see the gentleman on the left can still see the game and he's getting no support. The person in the middle has some support and is seeing the game, and the person on the right is getting the most support, and they're definitely able to see the game. So now everyone's able to see the game. So we're like, oh, good, people are being treated equitably. But the problem is there's still a barrier between them and the game. They still need extra support. So that's when we turn to things like justice. So justice is when you can see the game without any support or accommodations, because whatever inequity that was a barrier between you and the game has now been addressed, and that barrier has been removed. So all of these factors are reasons why when we talk about needing to target certain communities for COVID-19, for COVID-19 vaccines, for getting people to participate, for getting the word out, for prioritizing certain communities. This is the reason why, because you can't just treat all communities equally when they're being disproportionately affected because of long-standing inequities that have affected those communities. Okay, so we talked about cases of COVID-19. Let's talk about death. All right. So tell me, based on this, based on what you guys know about systemic inequities now, about community health, about underlying diseases and all this that we just talked about, what proportion of cases or of COVID-19 affect, now these are comparing to white people now, okay? What proportions would you say affect Latinos? Would you say that Latinos have a case rate of COVID 1.5 times higher, 2 times higher? What would you guys say?
2 times.
2 times? So this is just cases. We're not talking about death yet, but just cases. Okay. So I'm getting a 2 times. Any other guesses? Someone's saying 3 times. 3 times. Okay. 3 times. Lots of 3 times guesses. How about if someone's saying 4 times? How about if you're African American? You're likely to getting a case of COVID-19.
5 times, approximately.
5. Okay, so 5 times higher. I'm hearing. Any other? 4 times higher. Okay, so definitely when you're comparing to the white people, you guys are definitely giving me some much higher numbers. How about if you're a Native American? American
Probably
Indian,
around
Native American.
5 times.
So someone is saying 5 times higher. So you guys are all giving me guesses that are much higher. Okay. And so why is that? Why is it that, so we talked about you're getting hospitalized more often because of underlying diseases, but now I'm just talking about you getting COVID-19 in the first place, just getting it at all. Why is it that these communities are getting more cases of COVID-19 compared to Caucasian communities?
So it could be due to employment and how if they're like in low income jobs, they have to go in person rather than working remotely.
That's an excellent answer. And so if you are working remotely and you're an essential worker, you can't not go to work. So you are exposed more often to individuals who may have COVID-19. And so you can't telecommute. I don't know if you guys know this incredible statistic, but anyone have any idea of what percentage of Latinos, based on their job, have the ability to do virtual commute or telecommute?
Probably like 15% or something that's low.
16%. 16% of all Latinos have jobs that allow them to do telecommuting, that allow them to work virtually. That helps explain an excellent answer, part of the reason why. Okay. How about other reasons? What's another reason why, if you live in some of these communities, that you're more likely to get a case of COVID-19?
Maybe not having access to like mask or any type of face covering.
So your access to basic things that can help you prevent a disease, not as much awareness. These are all very good answers. There's one other big one. What's one other component that public health people say? They say, wash your hands. They say, wear a mask. And what's the other one?
Social distance.
Right. Social distancing. So who thinks that if someone is living in the third ward, that they have a house that has 5 bedrooms and 4 bathrooms? Who thinks that that is likely? It is unlikely, right? That's just not going to happen. So what is your ability? Let's say someone in your house who is an essential worker gets COVID. What's the likelihood that people can adequately quarantine for 14 days and socially distance so that no one else in the house gets COVID? Pretty
Very
low.
like low.
Yeah, pretty low. And so when people say things like, well, if they were just, if those communities were just more careful, well, it's hard to quarantine when when you have 5, 6 people sharing in one bathroom, when you have 3, 4 people sharing a bedroom, right? And so these are all really important factors when you're thinking about even who contracts COVID-19 and why they contract COVID-19. So here's some of the stats that we talked about, all right? So you guys were very good on the money here. So if you're Latino or Native American, your likelihood of getting COVID is about almost 3 times higher than Caucasian populations. If you're African American, it's about 2.5 times higher, and it's slightly higher if you're Asian. Getting hospitalized starts really changing the game here because we talked about those underlying medical conditions, right? And so if you're a Native American, you have the highest risk of getting hospitalized after getting COVID because of these underlying medical conditions, because of systemic inequities and racism that we talked about. And so 5.3 times higher. If you're Latino or African American, it's 4.5 to 5, or excuse me, 4.5 times higher roughly. And if you're Asian, it's 1.3 times higher. How about dying? So if you are an African American, you have a 2 times higher rate of death than if you are Latino or Asian or Caucasian for that matter. And that is 1.5 times higher if you're a Native American. And so all of these statistics, this doesn't just point to some of those underlying medical conditions. Some of these things point to other things. How much when you show up at a hospital, how good is the hospital to take care of you? What are the resources that they have? How much money does the hospital have? Well, the money that they have depends on the area that people live in. And so people that live in less resourced areas or that are more poor have hospitals that have less resources as well, oftentimes. And so these are things to think about when you're considering all those. All right. Social determinants of health. This is a term that we use a lot as well. And I want you guys to be familiar with this because this has to do with the health of a community. And these are basically conditions that people are born into, that they work and live and age in. And it basically are things that form and shape your life and eventually your health as well. So we talked about education, where you live, how safe is the area, how economically stable is the area, what is the healthcare access in that area. And all of those things end up affecting other areas too. Okay, so it ends up affecting what's your ability to pay your medical bills or being in debt. What is the transportation that you have to a good hospital or good doctors? Can you walk? Doctors will say, hey, you know what? You need to walk more. You're overweight. Well, can you walk in your neighborhood? Is it safe to walk in your neighborhood? Getting higher education. So graduating from high school, having a higher access to healthy options. Some places don't have grocery stores for miles. And if you don't have a car, you can't get to the other grocery stores. Other social community engagement. So the people in the community care about, trying to improve that community. How much discrimination is there against that community? And then of course the healthcare system. What is the quality of care? Do you have insurance? How many providers are there to take care of individuals in the community, et cetera? So there's one other major area that I want you guys to understand about how it is that communities of color have been disproportionately affected by COVID-19 and why it is that you're hearing now in the news things like people really are scared of getting the COVID-19 vaccine, that there's less rates of COVID-19 vaccine that are being accepted by communities of color. Why is that? Well, the reason for that is that history matters. history of the United States and how people were treated medically matters. People remember these things and they impact communities pretty profoundly. So has anyone here heard of the Tuskegee Study? Anybody heard of what happened in Tuskegee, Alabama? So this is a study that happened back in the 1930s. This is happening at the same time as that housing discrimination business that we talked about. So this is where they had a bunch of African-American men that took part in an experiment, except that they didn't know that they were in an experiment. And that experiment was, what happens when you get syphilis? So they had this STD, they had syphilis. They were not told that they had syphilis. And they were told they were going to be treated in a study, but in actuality, the study was just to see what happens if someone has syphilis and we don't treat you. So even though at that time we had treatment for syphilis, the researchers were pretty unethical and decided to just watch and see what happened to these Black men and not treat them and tell them they were being treated, or not tell them at all that they had syphilis and just see what happened. So you can imagine that there were some pretty bad outcomes of people who have syphilis that go untreated. It's one of the worst STDs that you can have to go untreated. And they ended up passing syphilis to their partners, to their spouses, to their children. And so there were a large number of people that were affected by this experiment that happened on these people without their consent and without them knowing. And so this is something that African-American communities, if you ask most people in the African-American community, they are very familiar with what happened in Tuskegee, and they remember this. And so they view themselves as kind of like medical experiments in the United States. There's a history of this. And so anytime some new treatment comes out or some new disease comes out, they are somewhat fearful that the same thing's going to happen again. And you can understand why, because it already happened in the past. It's not just African-American communities, though. This happened to Puerto Rican women. So Puerto Rican women in the 60s, when they were trying to experiment on birth control pills, they said, hey, you know what? We need to have to see if these birth control pills are safe. So let's just give it to someone. We can't give it to someone in the United States because they'll find out about it. Let's give it to Puerto Ricans. So they gave it to Puerto Rican women who knew something. They knew that they were taking this pill to for some reason for their health, but they didn't know why. They didn't know the risk of taking the pill. Many of these women died, and nobody knew exactly what they were taking or why they were taking it. And so they were kind of like guinea pigs for the first birth control pill that we now have in the United States. And then I don't know if you guys have heard of this lady. This lady is Henrietta Lacks. She's a woman back in the 1950s that had cervical cancer. She died really young. She died at 31, but her cervical cancer cells, unlike most cells, could grow really easily in the lab. So people used her cells without her permission. They sold them to different companies without her permission. They gave her medical history to different researchers without her permission, or her family never saw any money from this distribution of her cells. They gave her entire genetic code publicly without her permission. And so a lot of these things then that happened are part of the reason why people don't trust the medical system in the United States. So people say, you know what, 1930, 1950, 1960, that was a long time ago. That's not happening anymore. Well, it turns out that it actually happened later than that. So this is something else that happened in the US, where if you were a Native American woman, that you had a risk of having a sterilization or having a tubal ligation or having a tubes tied so you couldn't have a baby anymore, when you thought you were getting an appendectomy. You thought you were getting your appendix out, and instead you were getting sterilized and you didn't know it. So this happened in the 70s and 80s, and it's estimated that as many as a quarter to a half of all Native American women were sterilized between 1970 and 1976 without knowing that that's what was going on. And so people say, well, that was in the 70s and 80s. I am sure that by now this has stopped. Well, it turns out that between 2018 and 2020, there were women that were in U.S. Customs and Immigration custody, and these women were given hysterectomies, or their whole uterus, the thing that allows you to carry a baby, was taken out without their consent. They thought that they were getting a procedure to assist them in some way. They were not consented for hysterectomies. There was one gynecologist who was doing a bunch of hysterectomies on these Latina women, and they had no idea. And this was happening as recent as over last summer, until someone blew the whistle and said, this is crazy, and this is not okay, and we need to look into this. And so you can see that there's a lot of reasons for communities of color Native Americans, African Americans, Latinos, to have some distrust of the medical system here in the United States. And so when we're looking at that, then we of course can understand why there is a vaccination problem with COVID-19. COVID-19 is new, the vaccine is new. And so people are like, you know what, you've already done this to me. You already experimented on me in the past. You've already lied to me in the past, or even in the present. And if you layer on top of that underlying diseases, if you layer on top of that underlying racial bias that happens every day, people get really, really distrustful. And so tell me, can anyone tell me, this is here looking at Texas, all right? We're looking at the vaccination data in terms of who is getting vaccines in Texas. So white people as a share of COVID-19 vaccines here in Texas. So Caucasians make up about 41% of the total population of Texas. What percent of all vaccinations have been distributed to Caucasians in Texas? Any guesses?
75%.
Good guess. So a high percentage. So 51%. So 51% of all people who have been vaccinated in Texas are Caucasian. Okay. How about African Americans? What percent of all African Americans? First of all, let me tell you that African Americans make up about 11.5% of all Texans. What percent of them have been vaccinated? Given what you know about underlying disorders, about systemic inequities, what percentage of them have been vaccinated? Something 30%, 20%, 25%. Orlando's getting hardcore with 10% over here. 7.5%. So 7.5% of all people that have been vaccinated are African American, even though they make up 11.5% of the population. Latinos in Texas make up about 40% of the population, so similar to the population of Caucasians, all right? And we talked about how Caucasians make up 50% of those that are vaccinated. What percent of all vaccinations have been distributed to Latinos, or have Latinos gotten, knowing that they make up 40% of Texas? %, 30%, 25%. Excellent, Janet. 15% of all vaccinations have gone to Latinos. So now that you understand kind of the entire landscape, this helps you understand where we are and how we got here, I hope. So last slide here, last two slides, representation matters, okay? This is why it matters who is saying, get a vaccine. This is why it matters that Black doctors are saying, get a vaccine. This is why it matters that Latino doctors are saying, get a vaccine. Because you cannot underestimate the fear in these communities based on what has happened in the past, based on the inequities, based on ongoing racism. You guys have all seen what happened with George Floyd over the summer. So these things are all kind of mixing together and kind of uncovering all of these outcomes of COVID. And so, for us, for doctors and medical professionals, I don't know if you guys know, but of all doctors, 6% of all doctors are Latino. Of all doctors, 5.5% of all doctors are African American. And so we are trying our best to dispel any myths and to get the word out. But we need to do our best to kind of change communities, change the minds of the communities about vaccinations and why they are safe, and explain to them that one of the main people that helped create the COVID vaccine is actually an African American scientist. So I hope that kind of gives you guys a general overview of community health, of understanding systemic inequities, of understanding medical history, mistrust, underlying conditions, all of it as it kind of pertains to COVID-19. And I'm happy to take any questions. I know we're up against time here.
Yeah, if you guys have any questions, drop them in the chat. We'll, I think, answer questions up until 12:40 if we need to. I think our next panel will be on the climate change one, and that'll start at 12:40. But I think some students had posted some questions here, but let me go ahead and see if I can find them.
So I see one question here. Do you think putting resources into community gardens to have a close access to healthy food would help? Can they be designed into all Spark parks? I think anytime you can give someone access to healthy food, it's helpful. That being said, that access has to be more than just food is here for you. That access also has to be, and it's affordable. A lot of times, if you have access to healthy foods or organic foods, or if you go to these like farmers markets, they're awesome, except that it costs like $15 for 2 carrots. Okay. So it has to be affordable in addition to being available. So I do think communities, and if they were educated on what to do with some of these foods, a lot of people have never interacted with a lot of the vegetables that you see grown in community gardens. If they were given instruction on how to make some of them, I think that would be very helpful.
So I think someone had asked that, 1 second. So one of the questions is, how can youth directly begin to start to solve some of your these problems that you've discussed, Dr. Lopez?
Well, that's a question that's a lot left up to you guys. Like, how can we? There's a few things, and I think Miss Depeche said a lot of these things. So, who is in charge matters. Who is in charge of your local community? Who is in charge of your city, of your state, of your country, of your Congress? Who is in charge matters, because those decisions make a difference in the communities in which we live. And so, for example, if you have individuals who don't believe that COVID exists, you're not going to get a lot of resources for COVID because they don't believe that it's real, because they think it's a hoax or a joke. And so if you have individuals who believe in public health measures, they're going to increase public health measures, for example. So voting and who you have in power is critically important. Other things that you can do, things like raising awareness of some of these systemic inequities and finding ways to combat them. So how do we change some of these longstanding systemic inequities? I think a lot of people need to get training on why they exist. They don't just exist because people are whatever stereotype you want to use. People are lazy, or people are, whatever the stereotype people are making about people who are disproportionately affected with COVID. I think understanding the history of these things and understanding how they became and how they happened is critically important to then saying, we can't let this happen anymore. And so educating people on the how and then coming up with the next steps, I think, is important. And there's so many areas that we can work on. I mean, I'll just give one example in my own area here. So like I said, 5% or 5.5% of all doctors are African-American. Less than 1% of all doctors are Native American. 6% of all doctors are Hispanic, 2% of which are Latinas like me. And so understanding how it is how to help people get into medicine, how do people get into healthcare? The more underrepresented minorities you have in healthcare, the more likely, the more you see people like you that can do it, the more likely you are to be able to go into it. Having people help with things like testing or help with things like applications are expensive. Helping with expenses, helping with debt relief. These are all kind of areas that people can target. And I mean, that's just a small example, but there's so many places where you can start. So many different areas. I want to like take all of your brains and put it in here, because it's such a good idea. Like, take all of the ideas that you have and channel them, because there's so many areas that need help that I'm sure you guys can work out an area that you can target.
Mm-hmm. And I think, so I got another question here. I'll try to rephrase this. So like you said, there's a lot of like mistrust, or there's not a lot of trust and like fear behind these vaccinations, right? So, how do we like approach these communities and tell them like it is safe? Because, it is a very delicate topic. Like, what is the best way to, I think, like tell like a family member or someone that we know that like taking the vaccine is safe?
Well, first, I think you have to tailor it to the community. So for example, a lot of times people will talk about African-American communities and getting the word out to churches where there's a lot of community African-Americans, or barbershops. or hair salons where people frequent so that they can have people, community healthcare workers in there discussing why it's safe. That approach doesn't work for all communities. So that doesn't really work for Asians. That doesn't really work for Latinos. So you have to know what approach works for what community. And so when I was working with the mayor's health equity response COVID-19 task force, we looked at some things like that, like what works. And so for Latinos, we knew that in order to get them to listen, we had to use media. So we had to use TV, radio, social media, live social media, because that was the avenues that they listened to the most. That was the avenues that were the most likely for them to access. It wasn't churches and it wasn't barbershops and things. And so understanding the community that you're trying to reach, I think is critically important. And then once you reach those communities, once you have their attention, having someone who looks like them, who can speak their language is helpful. And then beyond that, showing data and showing why it is that this is not scary, and showing how many people have gotten this safely. So data is pretty important too. But I think some of those other things matter a lot as well.
Cool. Well, thank you very much, Dr. Lopez, for spending your time with us here today. We really appreciate all of the kind of cool knowledge and tidbits that you kind of given us today. I think a lot of students have been messaging me in the chat saying this presentation is fire. So, I think everyone really enjoyed it. We really appreciate you, giving us a portion of your day on Saturday. And we will, I think if I get some more questions, I'll try to see if I can forward some of them to you. And again, we really appreciate you kind of coming out and speaking to us.
Well, I really appreciate you guys doing this on a Saturday. I mean, I'm trying to think, when I was a teenager, did I ever do this on a Saturday? I don't remember. I don't remember if I ever did, but I think the answer is probably not. So I'm incredibly impressed with the fact that you guys are invested in this and you guys are interested in this. And it speaks a lot to who you are and the stuff that you guys are capable of. So I have big hopes, big wishes for you to do awesome stuff. Okay. So do good stuff, do good work.
Will do. Thank you very much, Dr. Lopez. We appreciate it.
Thank you.
Talk to you guys later.
I'll hand it off to Vaishnav here.
Great. Well, Dr. Lopez just gave us a phenomenal workshop on our COVID-19 challenge.